My name is Marcella Termini, and for those who may not be able to see me, I am a very pale white female with curly shoulder-length red hair. I am wearing a green t-shirt and a black hoodie. Sorry, I lost my place there. Green t-shirt and a black hoodie. I use she, her pronouns, and I am a Rights and Democracy member. I serve on the leadership committee, and I am also part of this healthcare justice team who is presenting the meeting tonight with PNHP. The members of the healthcare justice team, and I hope I have everybody, are Jody Newell, myself, Jonah Wheeler, Beverly Pietlicki, Laura Mitchell, Laura Lynch, Lynn Merlone, Candace Moulton, and Heather Stockwell is the Healthcare Justice Statewide Campaign Organizer with Rights and Democracy. And I do have a few housekeeping notes. We're going to be recording the meeting tonight, as you just heard. So if you are uncomfortable being seen on camera, you can absolutely turn your camera off if that will make you feel more comfortable. And we also understand that our presence can vary in these Zoom meetings. So we encourage you to do what you need to do to feel comfortable in this space. That could look like having your camera on or off, if you need to stim or draw or anything that really helps you to be present and comfortable while you're with us tonight. So,
can I say one thing real quick?
Absolutely.
Thank you. To be sure, for those who are on the camera, have their camera on, make sure you hide your backgrounds to prevent scammers from taking advantage of you, if you know what I mean.
Thank you.
I think that's disabled on this call, but that's a good point.
Well, I can see your background. You should probably change it to, choose a virtual background. Go to camera.
Yeah, it's disabled on this meeting. I'm sorry about that.
Oh, what is?
The video backgrounds or filters, I believe.
Oh.
Yeah, you could have.
Well, you should enable it so that way no scammers can take advantage of anyone here.
I can't do that. That is our data and communication staff that has decided that is not going to be allowed because of Zoom bombers, where people take over your Zoom. So that's why it's like that.
Oh, okay. Or at least blur the background like what Donald did.
I will try that after I get through my spiel here. So I will continue. Thank you for all of that. So if anyone has any questions, please put them in the chat, and we will get to your questions. I also would it would be fantastic if everyone could introduce themselves in the chat using your name, where you're calling in from, and pronouns. And kind of going along with what I had just said before this, we do ask that you keep your microphone muted unless it is question time or if we ask you to unmute it. Other questions not related to the material tonight that you might have, if you write them in the chat, we will get back to you via email or a call if we have your phone number. So we do encourage the use of the chat. That will be monitored. Also, we have enabled closed captioning. If you would like to use this feature, you will go to the bottom of your screen and you'll see either an icon with the letters CC, or there may be 3 dots, which when you click it, it will bring up another list of options and you will see the option for closed captioning there. If you would like, if your screen on your little Zoom panel of yourself has your name, you can click to change your name if clicking on the screen where your face is. So that is an option as well. Would love to see your name on there. And so now I will introduce Rights and Democracy. The Rights and Democracy, RAD or RAD, is C4, and the Rights and Democracy Institute, RDI C3, work across Vermont and New Hampshire to advance human rights and a healthy, just, and equitable future for our communities. RDI's leadership development programs, and issue-based campaigns encompass a range of organizational and movement-building work, including economic, education, and racial justice, as well as universal health care, climate justice, and childcare access. And now I am pleased to introduce Dawn Kolish. I'll turn it over.
Hi, everybody. Sorry, and of course, my landline just began to ring, so I apologize for that. So I'm a family doctor, and I'm here because I'm lucky enough to be the convener of the New Hampshire chapter of a national organization called Physicians for National Health Program. When I became a charter member of Physicians for National Health Program back, I think it was around '87, I was sure that we would solve this problem in about 5 years, because it was very clear to me that there was no way that this crazy U.S. healthcare system could continue as out of balance as it is and as it was. There were too many people who didn't have insurance, who couldn't get health care, and costs were just going up. So I said, within 5 years, this whole thing will collapse. So we need some sort of national health program, and I joined that organization. And darn if every 5 years I didn't renew my prognostication that within 5 years the whole thing would collapse. Well, it hasn't collapsed. It is merely, in some ways, gotten worse, in some ways, gotten stronger. And that's one of the things that we're going to be talking about this evening, the ways in which the profit motivation within healthcare has made the system harder to fix. I've had a full career of being with patients who say, once I get to be 65, I can get onto Medicare, and then things will be better. And they're right. Medicare is a terrific program. It is effective. It pays providers, doctors, nurse practitioners, physical therapists, hospitals directly. And it does so with very low overhead, only about 2 or 3%. And it's available to everybody over age 65. Also, a few others, people who are disabled are eligible for Medicare, and people who are blind or have end-stage renal disease. And that was the end-stage renal disease patients had a great lobby back in the early 70s. But for that reason, because Medicare works so well, those of us who've been involved trying to develop a national health program came to use Medicare as the model. It works so well that we've said the best thing to do would be to have Medicare for everybody. Instead of having Medicaid for children and pregnant women and low-income people, and instead of having commercial insurance, which is so highly variable, and then when you turn 65, get Medicare, Medicare for everyone. And we learned and we worked to have Medicare be improved, because those of you who are on Medicare know that it still has deductibles, still has copays, and there are many things it does not cover. So we now talk about improved Medicare for all, so that improved Medicare for all covers from $1, no deductibles, no copays, and it includes some of the biggest things that traditional Medicare did not have, which is vision, hearing, dental, and long-term care. So the bills in front of Congress, the improved Medicare for all bills, have those features. And we were going along nicely in that direction, but we knew there was something around the corner that was going to be trouble. And it's turned out to be big trouble. That small thing was called Medicare Advantage. And Medicare Advantage has been around since, gosh, I think some of my colleagues here might know, around 2000. And it started, it was very small. And the way that Medicare Advantage works is that it is a HMO capitated, where instead of the money going directly from Medicare to the doctors, the money goes from Medicare to an insurance company who then manages the care of the patient. Well, it turns out, and my colleague Thomas will be going into more of these details very soon with some good slides. It turns out that Medicare Advantage costs more and delivers less, but they've got great publicity and a very strong lobby. So Medicare Advantage, number one, has mushroomed, and number two, it has spun off another evil plan called direct contracting entities, and then that evil plan, which is like Medicare Advantage on steroids, took a turn and changed its name to ACO REACH. So what used to be a tiny threat to Medicare has now turned into a major threat to Medicare. And we have to be very careful. We may no longer be able to say Medicare for all, because Medicare is under attack, and it's under attack by the capitalists. So I would like to introduce my colleague Thomas Lane, who our chapter of Physicians for National Health program has been so lucky to have walked up and introduced himself to us and said, you know, I'm a Dartmouth College student with a strong interest and some background in health policy. Can I intern with you? Well, darn if he hasn't turned out to be a terrific blessing for our organization. And he's the one who's put together the presentations that will go into more detail of some of the stuff that I've outlined. Before I turn it over to you, Thomas, let me just ask if anybody, knowing that Thomas isn't going to go into the details, but does anybody have any questions for me before he introduces you to that deep dive? And I do want to point out that if you look around at some of the faces, I recognize at least 3 PNHP colleagues, past or present. And so there are going to be a bunch of us on here who can answer questions and also ask questions. So
I think that we'd like to hold off on questions until the presentation is done, so that we're not going down a rabbit hole.
Yeah, I think that makes sense. But when it comes time to answer questions, my friends Mark, Ken, and Ahmed may have some of the answers, as well as Thomas and myself.
Awesome. I'm going to try to get you all pinned on the screen at the same time during that section too.
Terrific. So again, thank you very much for having us. It is RAD and PNHP have been working together side by side, hand in hand, shoulder to shoulder for a while, and we're thrilled to be working with Marcella and Heather and the other RAD team on this project tonight. Thomas, it's yours, man.
It's me. All right. Hello, everyone. As Don said, I am a Dartmouth College student. I'm originally from Minnesota, but I am out here now, and I study health policy. So that's how I got into PNHP. I'm a current sophomore. So let me share my screen here. Heather, if you could let in my little twin, so there we go. Oh, and you're gonna have to enable. Just say something when it's ready.
I apologize. I'm trying to find you on this list now.
No worries.
All the participants here.
No worries.
Let's see. Other Thomas Lane. Okay, found you. We're gonna make you a co-host. Yes. There, I think that should do it, but I also want to make sure you are both, oh, great,
There we go.
perfect.
So, welcome everyone. All right, so what I am going to be talking about is first is sort of the overarching theme of how this bill works. Medicare Advantage and now ACO REACH, which is new. And that is privatization in healthcare. This is sort of the thing that ties it all together. So I guess just to start off, I should probably explain what privatization is. For our purposes, privatization is when a service previously provided by the government is sold off to a private entity, and that's usually a company, but sometimes it's an individual, sometimes it's something else. But the bottom line then is that after the government sells that service off, the private entity then provides that service. And privatization is currently going on in our healthcare system. Again, Medicare Advantage, which has been going on for a while now, and then the ACO REACH, which is pretty brand new. Sort of example of privatization is actually the railroads in many European countries in the last few decades. Previously, the railroad tracks and the trains were all run by the government, but in recent decades, they have been sold to private companies. And now, if you go on the train, it's not run by the government, it's run by some company. And there are a lot of problems with that, but obviously that's not what we're talking about today. But that's just kind of an example of what privatization is in a more normal context than healthcare. So the way that I'm going to explain how this works, I'm an economics student, that's how I sort of study health policy, is I'm going to make an analogy to furniture stores and firefighters. And we're going to compare both of those to healthcare to sort of understand how this works, or well, better put, doesn't work. So let's say, hypothetically, that I want to buy a new sofa. A fairly normal thing. And the bottom line here is that I have lots of choices. Okay, if we just think of the furniture stores, chances are there's a bunch of furniture stores in my area. There might be some chain stores. I could go to an antique shop. I could go to a garage sale. Who knows what all there is? Lots of options. Not even to talk about, say, online options. Lots of places where I can buy sofas. And then within each sofa store, well, furniture store, I should say, each store is going to have many different sofas. If I go into the big furniture store down wherever, I probably can pick up, there's going to be a whole room full of sofas. I went to the IKEA website the other day here. And if I were to drive down to Stoughton, Massachusetts, it's the nearest IKEA, I have 818 choices to choose from. That's a lot of sofas. Hopefully I can see them all. They may not have all of those in the store, but they can have them mailed to you. That's a lot of sofas. The next part, I can easily compare prices. Okay, on the website here, prices right there, easy. If I go into a store, there'll be a price tag. There's no doubt as to what the price is. And I can usually assess quality too. If it's online, there might be reviews. If I'm at a store, I can, look at the sofa, touch the sofa, whatever I want, sit in it. And I can generally assess quality. And the bottom line here is that I can make a rational, well-informed choice. I can make a choice that chances are I will not regret. I will walk home with a sofa that I like. And in 6 months, a year, chances are I'll still like that sofa. And that's really important. So now let's compare that to healthcare. Again, we talked about furniture stores. Now there's probably lots of different stores that I can go to. Think about, clinics and hospitals. How many of those are in your area? Just think that's yourself. Chances are there may be a handful, but there's not that many, especially when it comes to hospitals. They're usually kind of spread out. And even if there is more than one, they may often be run by the same company. So we might have a situation of a monopoly where there's only one company in an area, a duopoly where there's two, an oligopoly where there's just a handful. And none of those are what we call a free market, which is how things sort of operate when I've talked about the sofa. Free markets are ideal for furniture, but that doesn't happen with healthcare. Let's say that I have a specific problem. Maybe I broke my arm. How many options do I have to treat that problem? How many different kinds of sofas do I have? Sort of to go back to that. Like, think of a catalog. Can I open up the broken arm catalog and choose what type of a treatment I want? No. You go to the doctor, chances are they put your arm in a cast, and then, you go through the rest of the treatment for that. There's no broken arm catalog, not that many options. So in prices, I have no idea what it would cost to get my broken arm fixed. I don't think anyone, I could find a range, it might be in the $500 to $1,000 range, or, whatever range, but that's not a number. Like with the sofas, it said exactly what the price was. But with healthcare, you can't really find that price. And then quality. You walk in, you don't really know what you're getting until after you leave. And at that point, you're on the hook. It's too late. So furniture, in economics terms, is what we call a private good. And it functions well in sort of the free market system because there's lots of choices and you can make an informed, rational choice to get what you want. With healthcare, you can't do that. At the same time, with sofas, furniture, you don't need a sofa. If for whatever reason I cannot get my hands on a sofa, that's okay. I'll live. With healthcare, that may not be the case. I could be injured, I might die, big problems. And as we saw, healthcare does not really function like the furniture store. I can't make a rational, well-informed choice. So now let's look at firefighters. So let's say hypothetically, not in real life, I hope, that my house is on fire. All right, what happens? I pick up my phone, I call 911, and what does 911 dispatcher do? They dispatch the nearest firefighter team from the nearest fire department. And they come along and they put my fire out and they rescue me and, do all the things that firefighters do. And that's the end of it. Well, let's think about that a little more. Going back to the furniture store, I had choices. When we think of the firefighters, do I have a choice of firefighters? No, because the dispatcher sent the nearest team from the nearest fire department. Frankly, I don't even think I want a choice because, if I'm calling on a team that's far away, they may not get to me in time. Again, going to like the competition aspect, those firefighters, they don't compete with one another. They're just there to keep us safe. They're not trying to, step on to do better than the other fire department. They're just trying to make sure that everyone is safe. There's no firefighter catalog. And with quality, you pick up the phone, you don't have time. Even if you could assess quality, you don't have time to. And obviously prices are irrelevant because there isn't a price, you pay for it with your taxes. So the bottom line here is that I can't make a rational, informed choice, well-informed choice when I pick up the phone, call 911, and tell them that my house is on fire. The dispatcher makes the rational, well-informed choice for me. So again, let's compare that to healthcare. Let's say if, I have a heart attack, what happens? Hopefully someone calls 911 and 911 dispatcher again sends the nearest ambulance. I get taken to the nearest hospital that can treat me. They wheel me in. I don't get to choose my doctors. I don't get to choose the procedure. There's no ER catalog that I get to flip open and say, oh, I want that one. There's no way to really assess the quality of the service that I'm getting. Because again, I'm not picking the hospital. I may not even be awake. The EMS team, is sort of making that rational, well-informed choice for me on my behalf. But I'm not the one making that myself. And that's important. So, okay, somebody might say, okay, well, that's an emergency. What about regular care? And again, as we talked about earlier, you don't have much choice. There's not much competition, not many clinics, hospitals, can't really compare prices. Quality is hard to accurately judge. And even if, say your doctor prescribes some sort of prescription drug, there's nothing really there either that's comparable to furniture. Chances are you don't know what it costs until it gets rung up by the clerk at the pharmacist. There's usually not very many companies that make the same product. And FDA approval for medicine that doesn't require that new medicine be any better than old medicines for the same purpose. So there's all sorts of different drugs swimming around for similar purposes, but there's no real way to tell which one is better than the other. Either you're not able to tell, or you need a doctor to tell. Even then, the doctor may not be able to tell. There's no real way to make those rational, well-informed choices that I talked about. So, going back to the fire departments and sort of the economics here, fire departments are what we call a public good, and they do not work in the free market system. They just don't function that way. With the fire departments, the community works together and pools money to ensure that everyone has access. And well, not just access, Heather was saying access is kind of a naughty word, but they get the service that they need. And that's what's really important here. At the same time, we all need a fire department. Even if my house never catches fire, my neighbor's house might. And the fire doesn't care about the property line. So, my house could catch on fire that way. And if my neighbor can't get the fire department to show up, I'm in trouble too. And as we saw, healthcare functions just like that. Healthcare functions like a public good. And that means it doesn't function in a market system. And when going back to privatization transitions things from being a public good to a private good. And that's why it doesn't work. You're trying to treat one thing as something totally other, and it falls apart. Markets are tools. With furniture, markets work great. There's no real reason, I don't think, for the government to be making furniture, but or even funding it. But with fire departments, with healthcare, it makes a lot of sense for the government to be funding it, because that way we all get what we need, because we're treating it as a public good. So that's what I've got for privatization. We think we're going to take a quick break for some questions on this part before we talk specifically about ACO REACH. I haven't been watching the chat, so if there's anything, Heather and the others, if you could throw any questions at me, or if people want to ask quick questions before we move on to ACO REACH.
I'm not seeing anybody, but if you do have a question on this section, you can either use the raise the hand feature at the bottom of your screen under the reactions icon, or you can also put into the chat that you have a question. And I think that was pretty straightforward for most folks, but yeah, just want to make sure people are understanding before we move forward.
I say go for it, Thomas. Jump in.
All right. Go for it. Next one.
I had a question.
Oh, sure.
I didn't notice my hand being raised.
Go for it.
Oh. Is the privatization of something always bad?
I like to say usually, because usually what they're trying to privatize is something like firefighters or healthcare, where it functions best as a public good. There are some instances where they privatize things that it's kind of ambivalent. I haven't really seen anything where it's been like really, really good idea. So usually I would say it ends up causing consequences that hurt people. And that's obviously not what we want.
Okay.
Cool. All right, I guess I will start with the ACO REACH. So what the heck is ACO REACH? They're formerly called DCEs, as Don mentioned, and they are similar to Medicare Advantage. They're kind of like the next step. So they're, even more sinister. And that's why we're focusing on them. So ACO REACH, originally called DCEs, direct contracting entities, started under the Trump administration. We at PNHP, we did a lot of organizing against them, and we managed to get the Biden administration to cancel them, which we thought was great. But then they turned around and they started a new program, this ACO REACH program, which is essentially the same thing, but with a new name and a bunch of fancy buzzwords thrown in to make it sound better. They called it Accountable Care Organization, realizing equity, access, and community health. And my sort of rule of thumb is if there's that many buzzwords in it, it's probably a scam. And spoiler alert, it is. It's not going to work the way we want it to. So ACO REACH, how does it work? So we're going to go back to our firefighters here. So imagine in your town, they decided they were going to close the fire department and instead hire a private company to do the firefighting. So this is sort of enough in the fancy jargon terms, they're privatizing the fire department. So now imagine when they did the bidding for the contract that they ended up hiring a long distance trucking company to do the work. Okay. And this company is going to be paid per building that they cover, with bonuses for covering extra risky buildings, so buildings that are more likely to catch fire, and then putting out more severe fires. So surely nothing could go wrong. Well, let's look at the list of things that could go wrong. So first off the bat, private firefighters are trying to earn a profit first and fight fires second. And that should give you pause. When we think of firefighters, they're here to fight fires, not make money. Obviously, again, looking at that contract that they signed, more dangerous buildings means more money for them. So what are they likely to do? They're likely to exaggerate the risk of those buildings when they build a city. So essentially, they're going to lie to us about how, the whole town, it's going to catch fire soon. Oh, no, you need to pay us a lot of money because we're taking on a lot of risk here. And then when fires do happen, they're likely to exaggerate the size of the fire because that gets them more money. Or even worse, let the fire burn a little bit so that they make more money when they put it out. And then there's also going to be no reason for them to encourage fire prevention. I remember in kindergarten that there would be firefighters every so often who would come into class and teach us how to, stop, drop, and roll, and what a smoke alarm is and all that sort of stuff. Because they wanted us to know that if a fire happens, what we should do, fire prevention. With these private firefighter companies, there's no reason for them to do that. Why? Because they're paid for, putting out fires. And then also because next year, the city is probably going to sign a new contract with a different company. They have, on an annual basis, they're probably rebidding out the firefighters to a new company. And so if they invest money in fire prevention now, and they're not the same, and they're not the one that gets the contract next year, they've wasted all that money. So there's no reason for them to do that. And again, the firefighters may not even be qualified to fight fires. Like look at that sort of the long distance trucking company. They may be great at hauling stuff across the country, but they probably don't know how to fight fire. They might be able to figure out a fire extinguisher, but they probably don't know how to use a fire truck or even have one. And that's worrisome. And in addition, because again, this is a private company, they're trying to make money. There's going to be a copay. And if you can't pay the copay after they put out your fire, the company takes your house. So, not only do you have a house that's been damaged by fire, but you don't actually have a house at all anymore. Lots of risks here, and not exactly what I would call great. So that's sort of how ACO REACH works. So with traditional Medicare, not ACO REACH or Medicare Advantage, traditional Medicare, what happens, the patient goes to the doctor sends the bill to Medicare pays at a preset rate, and it's very simple, it's very efficient. Bill goes out, money comes back in, end of story. With ACO REACH, Medicare contracts with a private company. Again, they're sort of privatizing themselves here, paying a fixed sum for each patient that the private company covers. And that fixed sum, they get extra money for patients with higher risks. So you have pre-existing conditions or some sort of health problem. The insured, the company gets more money. And there's some important rules that the program has, is that only 60% of that payment the company has to spend on healthcare. The rest can be administration or profit. For traditional Medicare, as Don said, that's a couple percent. So a couple percent going to administration because there's no profit in traditional Medicare, versus up to 40% getting, for all our purposes as patients, thrown away. And then probably one of the ways that worries me a lot is that patients are put in the program without their consent or knowledge. Here in New Hampshire, there is one of these ACO REACH. I believe it's down in Derry. So it's here in New Hampshire. It's spreading across the country. It's very worrisome. So yeah, what could go wrong? Going back to the firefighters here, the ACO REACH program, they make more money if they lie about how serious their patients' problems are. It's called upcoding. It already has been happening in Medicare Advantage, because again, Medicare Advantage is sort of like the slightly less privatized version of this. Patients have a choice with Medicare Advantage. With ACO REACH, they don't. And so what they do here, if you look at this graph here that I stole from a PNHP document on Medicare Advantage, because again, it's the same problem. If you look on the left here, we've got sort of a generic senior citizen patient. You know, they've got some problems. They get a sort of they call it a risk score. And that ensures sort of, and that determines like the bonus that the insurance company gets for covering them. But if they upcode it, sort of make the risk look worse than it actually is, essentially, you know, defraud the government here and us as taxpayers, they get a ton more money. 32,000 versus 9,000. That's a lot of money just by fudging the paperwork. And that's something that can and probably will happen with this ACO REACH program. In addition, again, they're private, it's a private company running it. They make more money if they deny you care. Because every dollar that they don't spend on healthcare, they get to keep as either profit or administration, which is essentially their salaries. It's, you know, we're lighting money on fire, we're burning money up, and we're getting sicker as a result. And even if you're not on Medicare, you're paying for it with your taxes. We all pay into Medicare. We're all losing money here, and it's you know, it's very worrisome. It makes us sicker. We lose money. Lose. So that's what I've got for you. Again, we can do questions. I recommend this website, PNHP, and I believe a few of their partners made it. It's called protectmedicare.net. And it's got lots of more information, lots of videos of people smarter than I am, explaining a lot of the same stuff that I have, but also some other things about Medicare, ACO REACH, all that sort of stuff. So I highly recommend checking that website out later on if you are interested. So I can again take questions now. I haven't been looking at the chat, so.
You want to just take it off screen share, and
Yes, I should do
in
that.
the room together and see each other's faces. Awesome.
Cool.
And I'm just going to put it on gallery view so we can see each other in the room who's on camera. Yeah, do folks, that was kind of a lot of information. Jeffrey, I think I'm going to wait on your question because we talked about that being at the end of the meeting. Does anybody else have a question right now?
I think I'm seeing Ahmed.
Oh yeah, Ahmed, I see you there.
You're muted, Ahmed.
And I'll just say Ahmed is also a doctor or a retired doctor with PNHP. So welcome, Ahmed, and thank you for joining us.
Ahmed, we need you to unmute.
Ahmed, you're muted.
There we go.
Okay, hi.
Oh, Tom, very good presentation. All I was just going to add was in the DCO, ask the question, who are the investors? They are
Right, yes.
private equity capitalists, venture capitalists. So the answer to that is what Willie Horton was asked, why do you rob the banks? Because Willie Horton said that's where the money is. You know, so compared to even Medicare Advantage, the most egregious for profiteers are the ones buying up or setting up the new DCE program. So whereas Medicare Advantage, their cap has been limited lately 6% over Medicare's overhead, at least if the law is enforced, Medicare Advantage. Whereas, as you correctly pointed out, 40% can be kept by the DCO companies. Number two, the difference is that a patient would not know that they are in DCO because it is the doctor, the practice that signs up is bought up. Whereas until recently, when Bill Clinton introduced Medicare Choice, which became Medicare Advantage, patients signed up, meaning that they were, enticed, but they signed up. So they knew they are in Medicare patients. But in this one, this is a very new one, they won't even know it. Thank you.
Thank you for that, Ahmed. I totally also forgot that we were going to just take a little short action break and let you all know that there are ways to take action. I encourage everybody to go to the PNHP website, and I'm going to drop a bunch of links into the chat because PNHP, the Granite State chapter, has a great page you can check out with all of their updates getting loaded on there. But I'm going to share 2 click to action emails, click to action emails. This is the first one, which is about Medicare privatization, but also related. We still are, encouraging our delegation to support the Medicare for All the legislation. It's already been introduced into Congress or the House. And tomorrow, actually, I'll put a link in where you can watch the budget hearing. Bernie Sanders will be reintroducing it, and you can watch it live on the budget hearing committee thing. But we encourage you to do these actions. They'll come up with a, once you put your information in with your zip code, it'll tell you, this is for New Hampshire residents. Sorry if you're out of state. I can hook you up with a national one if you want to do that as well. But it will send a preloaded email to our delegation. You'll also be able to edit that and add your own personal story in there. So I've already gotten my response from both of our senators, which are pretty lame. So I encourage people to take action and send them more emails so that they really understand this is something that we need. And I'll be adding some other things. We have some events that we'll be at and stuff too that I want you to know about, but we'll get back to that later and let y'all continue because I see Gwen's hand up and I really want to hear that.
I saw a question in the chat about just what is an ACO. I think we should probably start with that one.
Yeah.
Did you work in an ACO or an HMO? I forget. Dr. Dolker?
Okay, well, that's not what I was raising my hand about, but that was a nice presentation, Tom.
Thank you.
Hold that thought about whether I work for an ACO, because I did, although my patients didn't know it was called Pioneer HMO that Dartmouth Hitchcock had signed up with. Just to let folks know that the reason that there is direct contracting entities, or what we're now calling the REACH nonsense, is part of the bill, which is the Accountable Care Act of interest. So the ACA, when it was passed back in 2012 or so, allowed there to be experimental programs offered by Health and Human Services that was outside of the province of Congress or our legislators. So these are basically trial programs in an effort to improve quality and reduce costs. And what was new, so ACOs are a longstanding concept under Health and Human Services, or Centers for Medicare Services, CMS, which runs Medicare and Medicaid. So ACOs have existed for some time. I was part of an ACO. Dartmouth-Hitchcock was one of many, probably about 400 multi-specialty programs throughout the world, throughout the country, that signed up to improve quality and get a bonus from Medicare for reducing costs at the same time. Unfortunately, a great concept did not have any results. It did not result in lower costs. Quality was negligible in terms of improvement. And the incentives were not properly aligned, essentially. So Dartmouth dropped out of that program and is no longer currently part of an ACO, even though, and if ACO sounds familiar to people from HMOs, there's a reason for that. Just some further history, some further background. Am I going on too long, Heather?
No, I think this is fine. I've put the four of you from PNHP in the spotlight so that people know that you're a special guest to help us answer some of the questions that folks have.
So folks have heard of HMOs, may not know the history of HMOs. HMOs were first designed by Kaiser Permanente in California back in the 1940s as a pre-capitation prepayment to physician groups to provide high quality care. In fact, Don is a family practitioner. The whole concept of family medicine was actually invented at Kaiser Permanente. HMOs used to be really the good guys. They were pinko experiments in reducing costs by maintaining people's health. What happened is they became privatized during the 1980s under the Reagan years. Medicine became corporatized. It became for-profit. Many of us who have gray hair on this call remember we used to have Blue Cross Blue Shield, which was a non-profit indemnity insurer, often worked out with folks' private communities. So HMOs came on the scene in the 1970s, but then they became privatized. They were traded on Wall Street. Their mission was to make a profit. That is, if you're traded on Wall Street, that's what your definition is. That's how you're founded as an organization. Medicine changed dramatically during the deregulation age of Reagan. So HMOs, which previously were actually folks were often satisfied, started to become draconian. There were utilization review nurses who would prevent you from having the studies that you need or the treatment that you needed. They became very unpopular in the United States in the 1990s. So many health insurers became ACOs, or now what we call managed care organizations, MCOs. So as a backlash against the public uproar, rightly so, for privatized HMOs or for-profit HMOs, a fellow by the name of Fisher at Dartmouth came up with a concept for accountable care organizations rather than health maintenance organizations. They're a different structure in that the insurance entity was separated from the health entity, but that's what the origin of ACOs are. Now what we're seeing with what Tom was presenting with DCEs or REACH is highly profitized, highly privatized programs that the patient has no idea they're enrolled in. So these are venture capitalists that are doing a lot of, that are jumping into the game. These are folks, again, trading on Wall Street to make their stockholders happy and to basically maximize profit. Unfortunately, that's not consistent with good medical care. If there's something, if you're trying to save the capitated dollars you're getting from the government and not expend it on healthcare. So someone asked, is privatize, it always bad to privatize things? No. Soviet Union tried to make growing wheat a process of their country. It's a lot better to have wheat traded to some extent, but there's government control, there's government regulation. The problem with DCEs is they're poorly regulated, and they're going to price out a lot of folks in the long run. We cannot afford to be spending 40% of our healthcare dollars to go to Wall Street. We are seeing that in the United States compared to other countries in terms of costs that are not going to the healthcare dollar. They're going to a private interest. Anyhow, I hope that answers some of the questions you asked for me, Tom. I'm going to shut up.
Yeah, excellent. Thank you, Ken.
I've got a suggestion for people a fun game to try. I don't want you to do it right now because it'll be so much fun that you'll leave this webinar. But you should Google ACO Reach, and you'll get two things if you Google ACO Reach. One is you'll get statements from the Center for Medicare Services talking about why they think it will help improve quality and cut costs. And in a minute, I'll explain, say a little bit more about why that isn't happening. But the other thing you'll get is a bunch of companies who are saying, we have wonderful software that we want to sell to your health system so that you can become an ACO Reach provider, and you can upcode. This software will help you upcode. It will help you tell at the very beginning who are going to be the most expensive patients so that you will not take them, and will help you set up your network of doctors and hospitals that will be limited, so that you can make more money. So the ACO Reach idea in some ways is good, isn't it? It's and I'm very grateful that I think it's Doug and Greg put into the chat their good experience with Medicare Advantage, because they say that it's, quote, value-based care, and they say that a private company will always do a better job of providing care that is higher quality and lower cost. And with apologies, I don't know if it was Doug or Greg put into the chat that they have actually had a good experience with Medicare Advantage not costing very much and providing them with good service when they were ill. And the reason that this can work well for private equity, as Ahmed was saying, is that if they provide high value care some of the time and get rid of difficult patients some of the time and upcode some of the time. Oh, and I want to slip in here, by the way, getting rid of difficult patients is called lemon dropping. That is, if a difficult patient is a lemon, and choosing healthy patients is called cherry picking. So we think that Medicare Advantage makes money by cherry picking and lemon dropping. They don't have to provide low value care all the time, Doug and Greg. All they have to do is work at the margins and sift away those people who are not only going to need surgery, but are going to need a lot of extra care over decades. That is, people with severe chronic diseases, and which, as they get more and more out of control, they get dropped by Medicare Advantage. So I wish that it was really clear so that there were the black hats and the white hats, or the good people wearing black hats and the bad guys wearing white hats. It doesn't work that way all the time. They make their money at the margins.
I see a question in the chat too, but I also see Ahmed wanting to say something.
Oh, go ahead, ask the person in the chat first, maybe.
This comes from Karen. Karen, do you want to come off mute and ask your question? Oh, it's not Karen, actually. Sorry.
That's Mark Patnode, who
Mark.
is a
Yes.
former PNHP member. Hey, Mark.
Hey, Mark.
Hi, Don. I'm unmuted. Good. I thought I was still a member. I'm sorry.
You are still a member. Just we miss seeing you at our meetings, but come on back. You ask great questions.
Okay, well, can we answer this question?
Why don't you ask it out loud, and our team of experts will do their best.
Excellent. Okay, my question is, can the United States have affordable health care without price controls? It's my understanding that every country that has affordable health care has price controls. It's also my understanding, I know this, that we don't see this ever discussed.
So I'll take a first cut at it. There are two big schools of thought as to why the United States healthcare costs so damn much. Just to remind everybody, we spend twice as much per person as the other industrialized nations. So why does it cost so much? The two schools of thought are, number one, that we do too much, that we order too many MRIs and we have too many hospitalizations and that we have too many doctor visits. The second is that things cost too much. Well, the ACOs, that is, the prices are out of control. The ACOs and Medicare Advantage do their work based on limiting access to services. They are in the first camp. They think that doctors and hospitals do too much. And they do not work on the price side for a couple of very good reasons, most of which is that because they are these are large companies, often owned by private equity firms, they actually make more money when things cost more. So
Right.
the short answer, Mark,
Don, can I explain that?
but please. So
Yeah.
the short answer, Mark, is going to be no. We cannot be done without controlling prices.
I agree, Mark, and I agree, Don, totally. By the way, the U.S. healthcare system suffers from pricing failure at every level. And if you think about how many folks are excluded from our healthcare system, the lack of equity in our healthcare system, we are paying extraordinarily high amounts, twice as much per capita as most other industrialized nations, modern nations. So when you go for your MR, it's not like in Europe, by the way, it's very important. If you're in France or in Germany or in Netherlands, you are in Japan, you're in Australia, you name the country, Britain, you're not getting less hip replacements. You're just paying $25,000 for a hip replacement instead of $100,000 for a hip replacement. You're not getting less MRIs. Ironically, if you're in Europe, you're having, the studies are very clear, you're having just as many MRIs, you're having just as many CAT scans. The cost is tripled in the US. And you could go on, the Commonwealth Organization has this data, KFF, Kaiser Family Foundation, there's a lot of data at your fingertips to see what it costs to have a procedure, to have a pacemaker, to have your appendix out. We suffer from pricing failure in the United States exactly for the reason that Mark raises, because we have no central control. There's no control on costs. It's what the market will bear. Think of pharmaceuticals. Every other country on earth that has a modern healthcare system has negotiations with the pharmaceutical industry to lower the cost of the drugs so people can afford them. Same thing with pricing failure in the US with our drugs. So it's an extraordinary lack of regulation that we were sold a bill of goods back in the 1980s. The free market solves all. It's the power of the free market, not when it comes to healthcare. Don, one thing you said, which is the incentive that, or the lack of incentive for insurers to lower healthcare costs, is remarkable. They make their profit on the percentage of the amount of the money spent for healthcare. So if you're getting 20% of $1,000 versus 20% of $10,000, you don't care. You make more money when healthcare costs more. It's what they submit back to the with the employee-sponsored insurers. Capitation, unfortunately. So anyhow, I think that's a really essential question mark.
I guess, oh,
Go ahead.
I guess the way that I like to kind of think about this is I like to think of, America like a pond. And in this pond, there's lots of different fish. The hospital conglomerates are a decent sized fish. The health insurance companies are a decent sized fish. There's all these different fish, but we patients are the little minnows. And because there's no real, everyone's just eating everyone, but us patients are eating everyone. We're always getting eaten. But what Medicare for All would do, which is what I like it so much, is because it would turn us, instead of being little minnows, it would turn us, represented via our government, into the biggest fish in the pond. So we can't get bullied anymore. It puts the patient first. And I think that's what's really important.
Oh,
I have if I could, my feeling is because our expenses are so high in this country. 8% of GDP for healthcare.
18.
We got rid of all the insurance companies. Yeah, and we insured everybody. And we still paid 18% of GDP. That would be a failure. Because the opportunity cost of spending that money on other social goods that prevent people from getting sick are too high. It doesn't work for other countries.
Yeah, Mark?
Yes.
I was slipping an answer, and then I know that Ahmed wants to also. We have a problem, so many problems, but one of them is that we have too many MRI machines, and we need to keep on paying for those. If it's going to be hard, it's a good goal to get down below 18% and to spend that money for the social causes of illness, such as poverty, education, housing. But at the very least, what can be done is for that same amount of money to now provide not only for 90% of people in the US who have insurance, and some of it is worthless, but for 100% of people, everybody to get covered, to get all the health care they need, including dental, vision, hearing, and long-term care. And we can do that almost with a flip of a switch and still with that 18% of GDP. Ahmed, your thoughts?
Oh, okay. Well, historically, I just want to make two comments. Kaiser Permanente, when they first proposed it as a model, comprehensive care at the end of World War II, because of their location in the late 40s, Southern California. AMA, especially California Medical Association, organized medicine, opposed it because doctors will then become salaried employees of a company, meaning that there were AMA's devotion to the individualistic control of the doctor's destiny in their own hands, that concept. For a long time, they opposed it. Any kind of, capitated, predetermined fee for, other than fee for service, AMA. So organized medicine still, especially at the national level, remains a formidable obstacle. Second was that I was listening to that speech live Nixon in late 71 proposed HMO basically as a counter to Ted Kennedy's national health plan, because summer of 71, that was very popular because Canada had just become almost, Canadian Medicare had extended to all of Canada. So Ted Kennedy had no problem, or at least was very popular, selling it mostly almost to both sides of the aisle. You know, Republicans were also pretty, you know, a good number, and moderate Americans. So Nixon came up with, on an absolutely political basis, to kind of get rid of Ted Kennedy's appeal, and proposed HMO. And just like Ken said, at the beginning, including my hospital and where we all thought that was not a bad idea. So for about 8 or 9 years, as you said, until privatization, you know, Reagan and late Carter, is when they were allowed to be privately run, HMOs, meaning for profit. And that is about the same time Blue Cross were permitted to become publicly traded, late 70s. In fact, Jimmy Carter allowed that. In fact, right now, there are only 14 or so Blue Cross plans of the old model. All the other Blue Crosses are now traded companies. So, you know, in other words, just like Tom said, America's, you know, what do you call it, fascination, preoccupation, and worship of the free market system has blinded us to, you know, the havoc that it is doing to an essential service like healthcare. And the only question we ask, or we should ask rhetorically, would United States Defense Forces, would we allow our Marine Corps, and you know, and not the contractors, but the service itself be privatized, like in the Middle Ages in Europe? You know, no, we have a national Army and national Air Force and national Navy, you know, and that is a kind of public good model that we, even instead of a small town fire company model, we could say, look, you know, we accept government funding and doing everything to keep us safe as a defense service. Whereas, one more thing, and then I'm in what we propose, Thomas, we are only asking, or still maintaining, that funding is public, meaning taxpayer, whereas all services, Medicare, except for VA and so on, TRICARE, military care, are still privately run. So even when the public picks up the tab, we, all doctors and nurses and everybody else, delivers the care in the same fashion as we have done for hundreds of years. Except that now lately, many doctors are becoming employed by the corporation. Even so, that is not the same as becoming a government bureaucrat. Thank you.
Thank you for that, Ahmed. Do y'all want to address this question from Jeffrey about who it is that's trying to privatize Medicare for all? I mean, I think, and why? And I would say that's private equity investors, and why is money. But question 2 is, what's the solution to prevent the Medicare, the privatization of Medicare for all? I know you sort of touched on this earlier, but maybe we want to just dive into that a little more fully. I mean, it's going to take us fighting against it and letting our representatives know. I'll say that.
I mean, frankly, it's just anybody who thinks they can make money off of it. They're pushing for privatization because, well, they want to make money. Politically, and a lot of it's Republicans, but there are a few Democrats too who think it's a good idea. So it's kind of a touchy, you know, who's got money where, who stands to benefit kind of a thing. But if you can figure out who stands to benefit, they're almost always behind it. And that's the case here with privatization of Medicare.
I thought there was an interesting question just asked on the chat by Gwen and Doug, who mentioned, I know it's outside the topic of this panel, but the same questions about who should be given healthcare, privileged versus non-privileged, are now coming up in housing as well. And it's very true. These are, as Tom presented, public goods. Having a place to live has always been helped to be designed by cities and city planners and zoning law and the like. What we have seen over the past 40 years is the privatization of everything must be the right step. What it generates is huge amounts of money for influencing our legislators. Again, by the way, most European countries do not have lobbyists the way the US does. So all of these things are happening simultaneously. We're seeing and we're sort of moving back to the days of Dickens, where the public good is no longer considered necessary. It's all the free market will determine who goes to the poorhouse or who doesn't. So I think it's true. All these things are interconnected. They're connected with campaign finance issues, with Citizens United, and a lot of other issues outside of the scope of this talk. But I think healthcare is an exception in that we all need it. And middle class is now finding that they cannot find their primary care doctor in their communities because there's no money to be made if you do primary care. The hospitals don't get much reward for it. They'd rather be sponsoring their orthopedic surgeons. You cannot, well, in any case. So I thought it was an important question.
I also, another way that I think about the insurance companies that are now being heavily capitalized by private equity, and I am not a high finance guy, but private equity are groups of money that have a lot of money and they want to make more, and they invest it in things where they get a lot of money quickly, and then they get out. So they are doing things like buying up emergency room physician companies, and then placing those emergency room physicians in hospitals all around our region and working them to the bone so that the emergency room doctors are exhausted, and then getting out, meaning that they then sell to another company. But they also are now capitalizing the ACOs, the Accountable Care Organizations, and I've put in the chat the link for America's Health Insurance Plans, or AHIP, and this is the industry group that coordinates most of the lobbying that the insurance companies do in Washington. So what Ahmed was saying about Citizens United points up the fact that, Heather, if we want our congressional representatives to say, out with the insurance companies, let's have a national health plan, let's have traditional Medicare for all, not Medicare Advantage, we need to have those representatives not be lobbied by the AHIP companies. And some of you, I'm sure, know more than I what whether the health insurance company, health insurance lobby is number one or number two in terms of dollars spent in Washington, D.C. But it is right up there. It might be number three. This is the sort of thing that Mark knows.
Big Pharma.
Pharma is number one. Yeah. Anyway, answer your question, Heather. We have to work at all levels in our political system to have the political system more accountable to the people and not to big capital.
Maybe it's time to switch from capitalism to something else.
Maybe.
So I think now capitalism has been corrupted and now has outlived its usefulness in a way.
I think there's all kinds of capitalism and there's all kinds of socialism. There's good capitalism.
Yeah, I agree with that part. It's who runs it that's to blame. That's to blame, you know. If you know what I mean.
Or it's how it is regulated.
Oh, okay, or that too.
Right. That's a good point. If it's not regulated, then it's letting the money run wild without any oversight at all. And that wasn't, I don't think that was my question, but I think I read it from the chat. But I would agree, we need to come together. We need to get people all over this country. You know, we're working on New Hampshire and Vermont, but it's a humongous issue to overturn. And I would say you raise a good question about capitalism. Capitalism is also shown to, at least the way we're doing it, to really be hand in hand with white supremacy at this point. There's a lot of evidence that really points to that. And there isn't equity in the system that we have now, because even people that are regular working people that have their private insurance plan through the marketplace or through their employer are not able to afford to actually go get the care, because after they pay $17,000 a year for their premiums, they don't have money left over to use for those copays and out-of-pocket costs, et cetera, et cetera. So it's not, even though you're getting that price tag of your premium, there are always extra costs involved, and some of those costs are quite high.
Capital or capitalism, capital captured our state, you know, so that from FDR, at least the last century, American state was a countervailing power to the corporate America. And that dialectic worked successfully until about Reagan, meaning FDR did not want to introduce any kind of dogmatic socialism, but as Don said, regulated, controlled, and that control had to be by the power of the state, especially at the federal level. So that, in fact, that's what Reagan's agenda through to Trump is. New Deal is a bad deal, and undo it all the way, including Medicare and Social Security. You know, unravel it and privatize it and get rid of it. And that's where we're heading. Thank you.
A state that's run democratically is what we need.
Yeah, but that state has been captured by big capital.
Right, which won't work. I mean,
yeah, in the name of democracy.
Yeah, you know, Gillens and Page, the professors from Princeton and Northwestern released a study 10, 20 years ago, and they looked at laws, and we don't have representative democracy.
No, I agree. Yeah, in fact, you know, what do you call okay, we don't have. We have a republic, elites republic.
When you let the elites make all the rules, you're in trouble. We don't have a democracy, and I think that's why a lot of people are upset about Donald Trump threatening democracy, because they look at our democracy and they say, you know what?
We don't have it.
I agree with you.
Yeah. Well, you know, I mean, the affluent state, the industrial state, Galbraith, you know, senior Galbraith and his son, they were all the ones, the New Deal economists, so to speak.
Countervailing forces.
Yeah, meaning countervailing power. And the countervailing power were for the people, American people. Whereas the capital, the 2%, 10%, they had the power already. Whereas the government, especially federal government, is the power that would regulate on behalf of the people, the majority, the public good, all the public good that we would value as a society. And that's being eroded. Anyway, okay, I don't know whether we come up with any solutions tonight.
Maybe one. Do you think privatizing healthcare should be a crime? Labeled a crime?
Like a punishable crime? That would be a little bit difficult, I would think.
Well, I mean, I think there could be civic penalties because private equity and health insurance companies have made so much money over the last 10 years of privatization that I'd like some of it back. Thank you.
Yeah, I mean, I think there's also some precedence in what's happening in the with the pharmaceutical companies who have like put out way too many opioids into communities, and now there are settlements happening, and so there is like money coming back, but that is that's going to take a lot of proof and lawyers and time, and I think that could be where we get to if we push hard enough and people speak up about this and contact their reps, et cetera, then maybe they will start getting the message.
And what it also means is that if there are any young people or even middle-aged people on this Zoom who are looking for work, you'll probably do better as a lawyer than as a doctor.
Speaking of money, the pros and cons of privatizing healthcare should be like this. If you want to explain, they get rich, but at the cost of human life. And and money can be replaced, but lives cannot.
Well said, Jeff. Heather, I think we probably should be figuring out how to wind down.
Well, I like to say one last thing before then.
Yeah, I think I took everyone off of Spotlight now, so we can just be, I'm gonna change it back to gallery view so I can see people again. Hey, I know that Jeffrey wanted to make an announcement about a couple of movies that he feels like really explain why we need Medicare for all. But I want to thank everybody for coming tonight too, and I'm still going to drop a few more links in the chat. We are going to be, we're part of an event on Friday. If you're interested in attending at the State House for reproductive rights for all of us. Yeah, I'm not even going to say women because we have a lot of folks that are transgender and things, and anybody that has a uterus, we could say. This is a really unprecedented time that we are living in, and we're having a rally or protest on Friday at the State House from 3 to 6. There'll be speakers and some great organizations there tabling and things, so you can talk, share your stories, and yeah, it's going to be a great event. So yeah, anything else before we start winding down?
May I say the movies? Okay, let me just hold on. I think it'd be good if I start my video.
Awesome, thanks, Jeffrey. We want to see you.
Whoops, Satan. Whoops, hold on. I gotta change that background. They're ready for another. Now then. Okay. The two movies I suggest seeing that explains about health that could, get the message about why we need Medicare for all are these two movies, Spider-Man 3 and John Q.
Can you tell us a little bit why you think that?
Yeah, I could do better. I could probably show you real quick. If you let me share my screen.
I don't think we have time for that because we're wrapping up. Just in a sentence or something, that would be fine. I mean, I see a couple of things like there are healthcare related things like somebody's health. In John Q, it says something about he needs a heart. Is that what it is?
Yeah, and people could do the fear of loss could lead people to do desperate things.
Yeah, Sandman's daughter.
Say that again.
In Spider-Man 3, Sandman's daughter was deathly ill, and it led him to a life of crime, which really speaks to a lot of where America is with our poverty and, really the way our system is rigged to keep people in poverty. And we wonder why we have the, our pipeline, leading people to prison because they're fighting so hard to get out of where they're at. And, yeah, et cetera, et
Goodness.
cetera. Good choices, Jeffrey.
Couldn't have said it better myself, Eric. I just put my email in the chat if you want to stay in touch with me.
Awesome.
Got it. I'll save the chat.
All right.
Yeah, I wanted to tell folks about a couple other events. I know I put something in the chat earlier about denials, and we've been doing this care over cost campaign last year and into this year because we're realizing nationwide we have this huge amount. It's 17% across the country, and New Hampshire is almost double that. 31.9% of all claims for private insurance are denied. And this is one of the big reasons that we really need to push back on the privatization of Medicare and Medicaid even as well. It's all being privatized under our noses. So we're going to be doing some surveying folks about their health care over the summer at a bunch of events. I'm sure we'll reach out to you about that. But if you're interested, also we're part of a national text bank with our friends at People's Action. And I'll put that.
You're muted.
Whoops. Okay, that took 3 tries to get it off mute. I'm putting this in the chat. The 25th in 2 weeks on Wednesday night. We'll have a little presentation about what this is about, and then there'll be a little training on how to text people, and it's all sort of set up for you. You use your computer, super easy, and you meet a lot of really cool folks. So look for things like that, and please, take action tonight with those links that I had shared earlier. And if nobody else has anything else,
I did put the link. I did put the link to a free version of the movie John Q in the chat. Chat. I even put a hashtag. I even put a hashtag in there called Stop Democracide. Since when you mentioned about democracy, I just put that in there.
Heather, it's Laura.
Okay, I'm just gonna say, I was just gonna say, I'm gonna stop recording now and sort of end this part of the meeting. And if people want to stay on and chat, that's great. Fine. For 4 minutes, but if you gotta go, you gotta go. Thank you.
This